Hi, everyone. Hi.
Hi.
We made
All right.
it.
Yeah.
We finally figured out the technical issues. Thank you guys for your patience.
Well, a few technical issues, but we finally made it. Sandra, do you want to go ahead and introduce yourself and then I'll start?
Sure. Hi, everyone. I'm Dr. Sandra Restaino. I'm a board certified physiatrist and pelvic pain specialist at Pelvic Rehabilitation Medicine in West Palm Beach.
I'm Dr. Marjorie Maye Mamsaang, also board certified in physical medicine and rehabilitation, fellowship trained in sports medicine, and I teach yoga, and I'm with Pelvic Rehabilitation Medicine in the Coral Gables office. So we're going to go ahead and get started. I want to show you this model just so you guys have a visual. It's endometriosis month, and we're talking. Still having technical issues, as you can
Right.
tell. Sorry about that. So it is Endometriosis Awareness Month, and we are talking about hip pain today. Before we talk about hip pain, I just want to do a quick review of what endometriosis is. This is the pelvis. So this is the front of the pelvis. This is the back. If you look at the side view, it's like this. So back is here, front is here. Your pelvic floor muscles are these fibers here down below. It's like a hammock or a sling. It holds all your organs up, including the uterus and the vagina. So, quick recap. What is endometriosis? Endometriosis is when you have tissue similar to the inside of the uterus, but instead of on the inside of the uterus, it's on the outside. So it could be anywhere here, over the pelvic floor, over the bowels, over the bladder. I only have the uterus, but the pelvic floor also holds the bladder and the rectum too. And then up top here, your diaphragm. So anywhere in this area, over the bowels or the bladder, can be endometriosis. Endometriosis is inflammatory and it's progressive, and it can cause quite significant pain. The very common symptoms are painful periods, but some women don't have painful periods. Sometimes they just have pain with sex. Sometimes they just have bladder symptoms like urgency and frequency. Sometimes tailbone pain. Sometimes just very bad constipation. So the symptoms vary. And the only way to truly diagnose and remove is with laparoscopic surgery. So sometimes women with endometriosis will have hip joint pain for whatever reasons, and Dr. Sandhu's going to cover some of those reasons right now.
Yeah. All right. Thank you, Dr. Mamsaang. The causes of hip pain and endometriosis typically tends to be multifactorial due to different causes. One of the main causes of hip pain and endometriosis is due to in the setting of chronic pain, especially in endo, you get chronic tensing and guarding of those pelvic floor muscles that lead to tight, weak pelvic floor muscles that can also lead to restrictions in the muscles, nerves, joints, and fascia and the surrounding areas like in the hip and groin that can lead to hip and groin pain. Also in the setting of endo, it's also known to be a systemic inflammatory condition. That part's also important to understand. And to know that the nerves tend to chronically be irritated and inflamed, especially in the pelvis. So when the nerves like the genital branch, the genitofemoral nerve, and the ilioinguinal nerve tend to be irritated, that can also lead to pain in the groin and the hip. Uncommonly, sometimes endo lesions can be found in the hip, but not super common. Can also be found around the muscles and nerves that surround the hip and groin area as well. And also there can be some injury, trauma, overuse, or hypermobility that can lead to pathology in the hip, like femoral acetabular impingement, hip labral tear, and also you can have sports hernias that can also contribute to groin pain. We also know that there is an association between autoimmune conditions and endometriosis, such as lupus or rheumatoid arthritis, that can lead to inflammatory arthritis in the joints, including that of the hip, leading to hip pain. Also, postural imbalances can occur, especially when those muscles are tight and weak in the pelvic floor. That can create compensatory patterns where the muscles of the hips and core have to work harder to kind of hold the structure of the pelvis intact. So in a way, we kind of think of the pelvis similar to a house where the roof, kind of like Dr. Mamsaang was showing you, the roof is the diaphragm, the floor is the pelvic floor, the front is the abdomen, back of the spine, and then the side are the hips. So whenever you have weakness in any one of those walls of the house, essentially, all the other walls have to work harder to keep the structure of the house intact. So similar, that's what's happening in the pelvis. So if you have weak pelvic floor muscles, the hips and the core and the surrounding structures are going to work harder to keep that pelvis intact. So you can have pain in those areas as well. So postural imbalances that can occur, you can have like tight hip flexors, for example, that can actually lead to anterior pelvic tilt, where the pelvis is tilted forward, and you can have rotational dysfunctional issues there in the hip, leading to hip pain. You can also have inflammation of the bursa that sits on the side of the hip that can lead to pain with side lying. Yeah, that's exactly where the pain would be. Thank you, Dr. Mamsaang. This is very helpful. And then also trigger points are common too, where you can have tight bands of muscle fibers that can refer pain. Specifically, like if you have trigger points in the hip flexors, those adductors, and also obliques that can refer pain straight into the groin and hip area. You can also have lumbar disc herniations, typically in the lower lumbar spine around L4, L5. That can also radiate pain into the hip. And lastly, pain in the SI joints. Either due to SI joint dysfunction or sacroiliitis, or inflammation at the SI joint, can lead to pain that radiates into the hip area.
All right, so multifactorial. And then some of the, just to orient you all, this is the pelvis, pelvic floor. The actual hip joint is here. So some of the things that Dr. Sandhu mentioned is maybe like a labral tear or a pincher. That basically means that your joint here is narrowed due to maybe a tear in some of this cushiony area that usually lubricates that joint, or the ball and socket is not super smooth. So then over time, it scrapes against that joint, becomes more narrow over time. When you have narrowing of this joint, that means that your hip joint, you now don't have as good range of motion as you did previously. When that happens, lots of compensatory patterns, like what Dr. Sandra Sandhu said. So when you don't have good range of motion here, your muscles of the pelvic floor also have to work harder, including this muscle here. It's called obturator internus. It helps with hip joint mobility. And when this muscle has to work harder, it also affects some of the nerves of the pelvic floor, particularly what's called the pudendal nerve that we always talk about. The pudendal nerve, it gives sensation to here all the way down to here. So for women, from the vulva, the opening of the vagina, all the way down to the rectum, so perineum, rectum. It also gives function to the pelvic floor muscles. And for women, it helps with sexual function, particularly orgasm. So when you have hip joint pain, you will likely also have pelvic floor dysfunction, other muscles that are compensating, and your nerves are also inflamed. That is part of your pain, along with endometriosis. We always talk about it's the pain process is two things really. It's the endometriosis lesions that's causing pain, inflammation, but also your muscles tightening and guarding, and the nerves getting inflamed. That's also part of the pain, and that's also what we treat. So all of our patients will get pelvic floor physical therapy. That way they learn how to relax those muscles, get some manual work internally to relax them. And the patient will also learn how to relax actively on their own. And then you will also, especially if you have hip joint dysfunction, incorporate some hip mobility exercises as well. And it will help to learn how to break some of those compensatory patterns too. What we do in the office to help with that, to get a better environment for your nerves and muscles to heal, we might do a peripheral nerve block to the nerves that are inflamed, including that pudendal nerve. And we might also do trigger point injections, which means we're just inserting a needle in externally using an ultrasound to the muscles that are tense and tight to get the muscles to release and lengthen. That is in addition to the pelvic therapy. Sometimes you will get some relief using muscle relaxer in suppository form. Suppositories are better because they get to the place, they're more localized and they're less systemic. And actually, if you were to take oral muscle relaxer, is not as helpful to the pelvic floor. So that's another thing that we do. For patients who have like outside of the hip pain, maybe your glute muscles are super tight, or you have like, it's not shown here, but if your leg muscle is here, that trochanteric bursa, because your glute muscles are so tight, it can get very, very inflamed. Sometimes creams can help with that. So a combination of maybe an anti-inflammatory cream, maybe ketamine for pain, to use as needed. That's also helpful too. Let me know, Dr. Sandhu, if I'm missing anything. SI joint pain. So it's really important that we talk about multifactorial reasons, because most of the time patients have chronic pelvic pain not because of because I just have this one thing. Usually it's because everything is connected and they all work together. It's multiple things and you have to treat them all separately. So some patients will also have sacroiliac joint dysfunction. This is this joint here, it doesn't move a lot, but when you have dysfunction, or if you have endometriosis and you're hypermobile, your ligaments in your joints are a little bit loosey-goosey, this joint becomes more mobile, and that causes pain in this joint here. Some patients describe this pain as low back pain, and you kind of have to tease it out. Is it like low back coming from the lumbar spine, or low back coming from the sacroiliac joint? Typical symptoms are like, oh, I have low back pain, one-sided, and especially when I'm getting in and out of a car, something like that. That's indicative of sacroiliac joint pain. So pelvic therapy will help with this, including compensatory patterns. Sometimes we'll do intra-articular joint injection into the space using an ultrasound to decrease some of that inflammation and help so that your pain will become more manageable, and then you can be more functional and get some more gains in physical therapy. Also, to help with sacroiliac joint pain is a Sorolla belt. It's basically a belt to brace your pelvis to decrease the mobility around the sacroiliac joint. And that way you can move around and go about your day, doing your daily activities without much mobility here. Over time, when you strengthen your core and all of your external muscles, you'll be able to decrease some of that hypermobility in that. And that's all I have, I think. I think we can probably, if you don't have anything to add, Dr. Sandhu, we can probably open up to questions.
Yeah, that sounds good.
Feel free to type your questions and we'll stick around. Thank you everyone for joining us.
Yeah, thank you guys.
Nobody has questions. Thank you, Dr. Taylor. Thanks for watching. Trying to think of some common questions that we might have. Oh, you know, something that I will add, for women with endometriosis and hip pain, when you have endometriosis, likely you've had pain for a long period of time. Anytime someone has pain for a long period of time, and when I say long period of time, more than 3 to 6 months, which is typically the case for endometriosis women, when you have pain for so long, your central nervous system gets kicked up. It's called central sensitization. It's basically means that your pain process changed over time, and over time your threshold for pain lowers, and the way that you experience the pain, it becomes more amplified over time. So a good example is of someone who's highly sensitized, is small movements or small provocation of pain, like just a small touch to their painful area, causes a lot of pain, and that's because their central nervous system is so high. So if you have endometriosis, you also have hip joint dysfunction, hip pain, your pain will likely appear to you as more amplified part of the pain process.
And sometimes with our protocol, that will help with that, with the treatment that Dr. Mamsaang mentioned, and sometimes we'll add in an oral neuromodulator to help decrease that central sensitization aspect of pain too. So that's something they might be on for about 8 to 12 weeks to help decrease that.
Yep, agree. Natural things you could do on your own. Big proponents of meditation and movement meditation like yoga, nothing crazy, just restorative things. Things like that help to downregulate your central nervous system too. And we have a question from Badania. So how can pelvic nerve and muscle treatments through the PRM protocol help with endometriosis pain? Great question. Do you want to go first, Dr.?
Sure. So like we mentioned before with endometriosis, you get that chronic tension guarding that leads to that spastic tight pelvic floor muscles, which then lead to irritation of the nerves where you have inflammation. So our protocol, we're targeting two things, the muscles and the nerves. With the nerves, we perform something called hydrodissection peripheral nerve blocks. We're essentially creating space around the nerve to bring in blood flow to allow the nerves to heal. And then we also perform trigger point injections of the muscles in the pelvic floor to help them relax and decrease that spastic tone over time. That will help with the healing process.
Yep, I agree. And I always recommend that you treat the pelvic floor first when you're suspecting endometriosis, because you'll have better symptom outcome. And most of the time your symptoms can be explained by the pelvic floor dysfunction. And if you end up undergoing surgery, there's decreased inflammation, less high tone, so it's not super tight in there. And so you'll have a better recovery. So it's that second part of what I mentioned earlier, how endometriosis usually is two parts when it comes to pain, the endo lesions themselves, and then the compensatory parts and the nerve inflammation that your body goes through. So that's the part that we treat. The next question, thank you, Dr. Sandhu, is from Momo FTO 144. I went through a series of 6 injections with no relief. I am on numerous medications. I have left vaginal pain. I did have adenomyosis in my uterus, but no mention of endometriosis. It cut off, but they want me to see it cut off there. But okay, so when I see a patient like you, when there is adenomyosis, unfortunately, we should talk about the possibility of endometriosis, just because when you have adenomyosis, there's a high correlation of women with adenomyosis, because adenomyosis is when there's endometriosis embedded within the muscle tissue of the uterus. So instead of on the outside, it's in the uterus itself. When you have that abnormal tissue in the muscle of the uterus, likelihood of having that abnormal tissue outside, aka endometriosis, is high. We are not surgeons, we're physiatrists, so we treat non-surgically, and we treat muscles, nerves, both. And we're functional medicine, so we can't technically diagnose you with endometriosis. But for someone who we've already done everything, very compliant, I'm sure you're also doing everything that you're supposed to be doing, and you're still not getting relief, that would be a good indication to maybe seek out an endometriosis specialist. That way they can also see if there is underlying endometriosis as well. There's always a reason. So when patients are not doing well, I tell them, and it's true, there's always a reason why patients don't do well. It's just a matter of figuring out what that barrier is. So it could be that, it could be other things. I don't know. And again, don't take this for medical advice just because I don't know your full case, but I'm just telling you what happens in a typical patient in that case scenario. Dr. Sandhu, do you have anything to add?
Yeah, and also a lot of times within the workup for endo, they'll typically order imaging, but just because imaging is negative for endo doesn't mean that you don't have endo. That's also important to understand too. Some types of endo, like chocolate cysts or deep infiltrating, may or may not show up on MRI. So I wouldn't solely depend on MRI to know if you have endo. Again, like Dr. Mamsaang mentioned before, the only way to really have that confirmation diagnosis and treat at the same time is with laparoscopic excision surgery. So up until that point, we can only suspect endo.
The last thing I want to mention is regarding this question is Dr. Sandhu and I recently went to the Endometriosis Summit where we met some of the top surgeons in the world and country. And if anyone, a loved one of mine had endometriosis, I would only send to one of them. The reason why is because you want a surgeon who sees endometriosis all day, every day. Otherwise, you might have someone that will go in who's very good qualified gynecologist that might go in, but because they don't see it all day, they won't be able to identify and then be confident enough to remove all of the lesions. So I would suggest you ask around in your local area or your provider who they recommend at the top. And there's good resources out there as well to see who's the best. The next question by Neri 2210. If the cervix is removed via a hysterectomy and orgasm are affected, can pelvic floor therapy help regain that sensation? Okay, so I can start. And part of sexual function is pelvic floor mediated, particularly the pudendal nerve. The pudendal nerve is what gives orgasm, that sensation of orgasm. It's involved in that, the pudendal nerve and the pelvic floor muscles. So I would start with pelvic therapy at least to make sure that your muscles are no longer so tight, because if your muscles are tight, they're squishing and compressing over the nerves of the pelvic floor, including the pudendal nerve, and that can make it so it can get chronically inflamed. And when the pudendal nerve or any other nerve is chronically inflamed, they either don't send signals properly or they send signals of pain. So in the case that you're asking, they could be causing anorgasmia or difficulty with orgasm. So you decrease the constriction around it by getting the muscles to relax. But the PRM injection protocol will also help to directly treat the nerve that is inflamed to help regain some of that sensation. When your nerve is not functioning properly, the best way I can explain it is like, in layman's terms, it's like when your computer is frozen and it's not functioning properly, that's what's happening to the nerve. So when we treat it with the injection protocol, we're desensitizing the nerve repetitively. It's almost like you have to reboot the computer to get it to function properly. That's what it's doing to the nerve. It takes some time, but eventually that nerve should be able to start firing properly.
Also to note, too, any kind of surgery in the pelvic floor, like a hysterectomy, it can also flare up the muscles and nerves. That's why when Dr. Mamsaang mentioned earlier, doing our protocol can actually help the muscles and nerves prep for surgery. So that way post-op, that helps with that post-op pain and recovery. So it's much easier for patients. As far as hysterectomy goes, it used to be falsely thought that would help cure endometriosis, but that's an old myth, as Dr. Mamsaang mentioned earlier, that endo is typically defined as it being outside the uterus. However, it is appropriate treatment for conditions that can occur with endometriosis, like adenomyosis or large fibroids. That would be more appropriate treatment for that.
Agreed. Next question, Momo FTO 144. Okay. This is the continuation of the last, so that they're recommending you to see a surgeon because they think it might be endometriosis. Should I do that? I now have severe pelvic pain from front to pelvis to the groin. So before we answer this question, I want to just clarify that since we're not seeing you as a patient, this is technically not medical advice because I don't know your full story. But for someone who they've been treated already for their pelvic floor, seeing a good pelvic floor therapist, very compliant with the plan, and they're still not getting better, there's usually a reason. So if someone is someone who knows your case is recommending that you maybe see an endometriosis surgeon, it might be a good idea to do so. Doesn't necessarily mean you go to surgery right away, but at least someone who's qualified in endometriosis can follow your case and see what the options are from there. Again, like what I would stress is that you see someone who only sees endometriosis. Look around, there's Facebook groups, there's other resources, your pelvic floor therapist, person who recommended your pelvic floor therapist might know people. I have a lot of patients. We're in South Florida, but we have good surgeons here. But I have a lot of patients who are willing to look everywhere and they travel. I've had a patient that traveled all the way to Oregon. I have many patients that travel all the way to New York, Texas even, because you want to find the best surgeon for you. See who's the best fit.
And also to note, within pelvic rehabilitation medicine, we do have some great excision surgeons to point out. So I would recommend checking them on our website. We have Dr. Haverland, Dr. McHale, and Dr. Bagaria. If anyone else I left out, I apologize. But they're all amazing, wonderful surgeons. So those are good recommendations too.
We might have time for maybe one more since we were running a little bit late. Laura. I see a question. Oh, from the person, or for the continuation of that, the question regarding endometriosis surgery without endometriosis known. I saw Dr. Kapadia in Dallas and being referred to, and it's cut off, but we both know that Dr. Kapadia is really great. She's awesome. She's amazing. So I think whoever she refers to you to is probably someone she's worked well with and who's had good experience sharing patients with. So I trust that referral. Okay.
They agree.
Referred to her partner. So guessing that. Do you know who the Texas surgeons are? Dr.
Haberland, I think, is out in Texas.
And Dr.
Houston.
McHale too, correct?
McHale, I thought, is in West Virginia, East Coast.
Fine. But I think that's a very good option for you.
And I always recommend patients to do your research too. So when you have your consultation with your endosurgeon, just be prepared to ask all the questions you need answered, because the part of having good outcome after surgery is creating that team that you trust. So you want to make sure that you have a good team supporting you behind you. That will help with your recovery.
Thank you, Britannia. Dr. McHale is in the greater DC area. We're stuck in our bubble.
Okay. Thank you, guys.
Awesome. All right. Well, I think this is a very good turnout lunch hours, but this video will be available to y'all as a recording later. And feel free to reach out for any questions. Dr. Sandhu, any last minute thoughts?
We're always here if you ever need anything, so reach out to us anytime. But this was fun. Thank you guys so much.
Thank you guys.
Bye.
Bye.